So it's my pleasure now to welcome Hedi Claahsen from Radboud University Medical Center. Hedi has worked a lot, and one of her major themes is actually congenital adrenal hyperplasia, and she will deliver the talk on current insight in testicular adrenal rest tumor. Thank you, Hedi. You have the floors now. The floor is yours.
Thank you, Michael, for this nice introduction. I hope you can hear me. Oh, and you see my slides, okay?
Yes.
First of all, I would like to thank the organizing committee for inviting me to this special symposium. I worked together with the IFCA for, I think, nearly 10 years. And I feel support and interest and compassion and the sincere intention to increase knowledge about CAH. And therefore, I would like to thank the organization, and especially Michael Pollack and his team of the steering committee, and also Christine Rougeau, for their trust and their support in the last years. Next slide. These are my disclosures. And now go to first. Okay, next slide. So just a few impressions about the country where I work. The Netherlands are only a small country, but with a broad culture, and the Dutch people are proud of their king, Willem-Alexander, and his family. You see here a picture of Willem-Alexander and his family, the typical windmills and tulip fields, and with the most bicycles per capita in the world, and below a picture of the current president, Mark Rutte. And here you see a picture of our university hospital with, on the upper side, the children's clinic where I work. So as Michael already mentioned, one of my main research topics in the last year is the etiology of testicular adrenal rest tumors. And these tumors are already described in many papers, mainly in case reports and in smaller cohorts. And because of their histological and functional resemblance with adrenal tissue, as I will discuss later on, they are generally called testicular adrenal rest tumors. And this was one of the most exciting things to consider, that there is kind of adrenal cells within the testes. In adult patients, these lesions are often found in both testes, about 83%, and with a typical central location within the testes. You see here a picture of a schematic picture of TART within the central location, the reated testes, and you see here a macroscopical picture with a typical appearance of TART taken from testis-sparing surgery. The tumor are benign, so it is no cancer, although some case reports also describe malignant lighter cells tumors in CAH, which are difficult to distinguish. But despite the absence of malignancy, because of this central location within the metastasis, the tumor may lead to obstructions of the seminiferal tubules, so the tubules in which the semen flows out, and consequently infertility, so a severe complication in adult CAH patients. And even more important, long-standing chronic obstruction may also lead to damage of the surrounding testicular tissue, and leading to complete damage of the testis with all functions. TART seems to be a typical finding in CAH, and it is often described in poorly controlled CAH patients, and therefore it is thought that elevated ACTH plays an important role in the pathogenesis of TART. Furthermore, several case reports describe shrinkage of the tumor after intensifying of the glucocorticoid therapy, with consequently also suppression of ACTH. And ACTH was also found on this TART tissue, as I will show you later on, Also, the adrenal origin of TART was suggested to be very likely. However, several unsolved questions exist. TART is also found in obviously well-controlled patients, and a clear correlation between hormonal control and tumor size has not been disclosed. And furthermore, also important is that TART is already present in childhood and even in infancy, and therefore our group hypothesized that TART may have its origin in fetal life, and that the origin may be a more totipotent cell instead of an adrenal cell. Based on our observations, we propose that the development and the growth of TART can be divided in 5 different stages as shown in this figure. And stage 1 is the stage that can be defined as the presence of adrenal-like cells within the center of the testis in fetal life, not detectable by scrotal ultrasound. And in healthy boys, these cells probably regress in the first year of life. But in the case of CAH, as in stage 1, 2, the adrenal rest cells may proliferate in the presence of increased concentrations of growth-promoting factors, such as ACTH. And in this stage, the adrenal rest cells may become visible by ultrasound or by MRI. As a typical hyperergogenic lesion, you can see that here in this slide. The age of onset of cell growth may depend on the cumulative exposure to ACTH concentration over time, so the amount of poor hormonal control, and probably also the number of ACTH receptors on the adrenal rest cells. Further growth, as in stage 3, of the adrenal cells will compress the aerated testis, so the tubules. And in pubertal or postpubertal CAH patients, azoospermia may already be found due to the obstruction of the seminiferous tubules. And in this stage, the tumor size may decrease after intensifying glucocorticoid therapy. Further hypertrophia, as seen in stage 4, will lead to progressive obstruction of the aerated testis and may also lead to the induction of fibrosis, something that we have seen on our histological studies. Fibrosis within the tumor, but also fibrosis in the surrounding testis. And several small tumors may confluate, forming a single lobulated structure separated from the residual testicular tissue by fibrous strands. And in this stage, high dosages of glucocorticoids are probably no longer effective in decreasing tumor size because of this fibrosis. And stage 5 is a stage of a chronic long-standing obstruction with damage of the surrounding testicular tissue, so irreversible damage. So how common is TART in CAH patients? And this depends on different factors. First of all, the method of detection. Usually only tumors of more than 2 centimeters are detectable by palpation because of this typical location within the testis, and therefore the tumors can be easily missed when additional techniques such as ultrasound preferable are not performed. And with ultrasound in adult patients, about 50% of CAH patients have TART. And here you see an example of TART by ultrasound, and in this picture, TART detected by MRI. Another important factor is the age of the patients. As I mentioned earlier, TART can already be detected in childhood, with also a clear increase in prevalence during puberty. And furthermore, TART is mostly described in patients with classic CAH, and therefore the severity of CAH seems to play also an important role. It is only anecdotally described in non-classic CAH patients. So our main research questions in the last years were: what kind of tissue is TART, and which factors lead to tumor growth, and how can we treat TART? So what kind of tissue is TART? In our tissue studies, we showed that TART indeed has...
Hedi, just the sound. Your paper on your microphone, I think. So please.
Yeah.
Yes. Because then the sound is scratchy, you know. Thanks.
Yeah, I see. So in our studies, we observed that TART indeed have typical adrenal features. They contain enzymes and receptors that are normally only found in adrenal tissue. So, for example, ACTH, but also angiotensin II receptors are typical findings in the adrenal gland, and that is also found in TART. And furthermore, we found that these tumors are also hormonal active, and they produce hormones that are normally only produced within the adrenal gland. But interestingly, we also found typical testis features, and therefore we concluded that TART has adrenal and testis characteristics. I come to this later on. First, I would like to show you the results of our recent study where we measured adrenal-specific steroids in spermatic vein samples of male patients with TART. And these are the veins that contain blood that come directly from the testis. So during testis-sparing surgery to remove the tumors, we took some blood samples of the spermatic vein and we measured, for example, 70-OHP. You know all this 70-OHP as a typical CAH marker, but we measured also elevated concentrations of 11-hydroxylated steroids, and that these are very specific for adrenal tissues, such as, and you can see this in this slide, for example, 11-keto-testosterone, and thereby we showed that TART produce indeed adrenal-specific steroids, so are hormonal active. To explore the features of TART in more detail, several years ago, also supported by IFCA grant, we performed a gene expression analysis by qPCR in several TART samples. And for this characterization, we selected 15 genes, including genes of all key steroid enzymes involved in the adrenocortical and the testicular steroid synthesis. And based on the presence or absence of these 10 specific enzymes involved in the steroid synthesis, the steroidogenic pathway was divided in 4 parts. You can see it here. There's a common pathway, the adrenal pathway, the testis pathway, and the peripheral part. And this figure, the results of the gene expression is shown within green, the results of TART tissue. And as you can see, we found gene expression of TART in the adrenal, but also of testis-specific steroid synthesis. And therefore, we concluded that TART indeed consists of a more totipotent cell with testicular and adrenal features within one cell. So our next step in the characterization of TART was the description of GATA transcription factors. These transcription factors are involved in the development and the differentiation of cells. And 3 GATA factors, that is 1, 4, and 6, are expressed in the cells of the somatic cells of the testes. You can see that here. While GATA 3 and 6 are more adrenal specific, and we wanted to know what is the expression of GATA in our TART cells. And here I show you the results. Results also performed after support by IFCA and performed by our PhD student Manon Engels, and already published several years ago. You see here in TART tissue, as well as adrenal, as well as testis-specific GATA factors, and again an argument to consider a more totipotent cell as the origin of TART. So we hypothesized what kind of, we wondered which type of cell could be the origin of TART, and one of the cells to be considered was the fetal Leiter cells. We know from the from the Leydig cells that they, during development, that there are two populations of Leydig cells, the fetal Leydig cell and the adult Leydig cells, and especially the fetal Leydig cells is a very interesting cell lineage, as these fetal Leydig cells have features of both adrenal and testis features, as they originate from the adrenogonadal primordium, so the common precursor of all steroid-producing cells. And when you compare these cells, so the fetal Leydig cells and the TART cells, you see many similarity. You see that the fetal Leydig cell contains the ACTH receptor, but also the LH receptor, and also some enzymes that are typical for the fetal Leydig cell, and is also found in TART. So this is one of the possible cells that can be the origin of TART, but we are not sure right now. Another possibility is a totally different cell, also from the from the primordial of the adrenogonadal primordium, with also common precursors and with a further development after stimulation by these growth promoter factors. Further studies have to be done to study this in more detail. Which factors lead to TART growth? We discussed already that TART contain ACTH receptor, and chronic exposure to ACTH, as occurs during fetal life and also in patients with poor hormonal control, will not only lead to adrenal hyperplasia, but may also prevent regression of these fetal Leydig cells, of these progenitor cells, and cause proliferation of these cells depending on the duration and the concentration of ACTH. And in addition to ACTH receptors, we also found angiotensin II receptors and also LH receptor expression. So probably poor hormonal control of the fludrocortisone treatment, but also puberty may be an additional factor in the growth of TART. And there are probably other still unknown factors that may play a role. So how can we treat TART? This is still a challenging question, as ACTH plays an important role in the pathogenesis of TART. We think that the first step in the treatment of TART is increasing the dosages of glucocorticoids to suppress ACTH. But we all know that an increase in glucocorticoids has also disadvantages, side effects. So this means that we have to balance the treatment to prevent over-treatment, especially in the case of TART treatment. But indeed, in some patients, the increase of glucocorticoid dosages will lead to a reduction of the tumor size and to also improving the testicular function. And these observations are described in several case reports. However, medical treatment is not always successful, and these serious side effects have to take in account. Surgery was performed also in several studies, but nowadays we know that surgery has also side effects, and that it can lead to additional damage of the testes. So this is not the first step in the treatment. And the current recommendation is still try to receive optimal hormonal control, try to evaluate TART by using ultrasound, so to detect them already in very early stage. We advise yearly ultrasound starting from the beginning of puberty, with also yearly evaluation of gonadal function in blood. And as hormonal treatment of TART is far from optimal, we also recommend cryopreservation in the case of TART, the presence of TART. So what are now next steps in studying the etiology of TART? We are now performing a study where we perform RNA sequencing to characterize TART in more detail, and we hope that we will find also still unknown factors that contribute to the development of TART. I hope to show you these results within several years. I come to my take-home messages. So I've shown you that TART is a frequent cause of infertility in CAH patients. TART are benign lesions. They are already present in childhood. They have adrenal and testis features. The origin of TART is not yet known, although we know more about several factors that contribute to the tumor growth. ACTH is an important growth promoting factor, and further studies will help to understand the etiology in more detail. And I want to finish with showing you our research team. On the right side, you see the research staff, Professor Frits Sweep, Dr. Paul Span, and Dr. Teun van Herwaarde. And at the left side, our PhD students who worked on the TART project. And this is our pediatric staff here at Radboud University. And of course, I would like to thank again IFCA for their support. And I would like to end up with the announcement of our CAH symposium that will be held in October in Nijmegen. Of course, you're all very welcome to visit Nijmegen in October. So thank you for your attention, and I'm happy to answer your questions.
Thank you very much, Hedi, for that very clear talk, which is open now for discussion. Martin, do you want to launch the discussion?
Yes, Hedi, thank you very much. We wonder, do you think the basis of TART is already laid during the fetal life, and is DEX treatment capable of reducing the risk of TART in the boy?
Yeah, thank you, Martin. This is a very good question. Indeed, we think that probably elevated ACTH in fetal life may play a role, as when you look at other acquired forms of adrenal insufficiency with high ACTH, there is the prevalence of TART is very, very low, or even zero. So there have to be a factor in prenatal life. I'm convinced that this plays a role. But on the other side, we do not have enough data to be sure that dexamethasone treatment probably could help, and I think it's also a hard study to perform. We discussed already that dexamethasone has also a lot of side effects for the mother and also for the fetus. So I think we should first collect more data to know a little bit more about what dexamethasone will do during pregnancy.
Mm-hmm.
Hedi, there are questions related to the way you take care of the male children with TART, or even young adults. Would you advise cryopreservation of spermatozoid systematically when you see TART? And the second question in the chat is, when do you start screening for TART in your experience?
Yeah. So our patients are quite well controlled, and therefore I start with the screening around puberty, starting puberty, when the testis volume is about 4 or 5 milliliter, and then we do that yearly. And when I detect TART, I follow these patients more carefully. And in the case of persistent TART, despite increasing or optimizing treatment, I discuss with the boy and also with the parents the possibility of cryopreservation. Yes, we counsel the patient about the possibility, especially when there is a growth of TART and when it does not decrease during the increase of glucocorticoid treatment. Yes, and this is also what we recommend in our guidelines.
Are your team of adult endocrinology ever use adrenolytic medication, as was done by Anne Bachelot team or other team in France to destroy actually the TART? And have they seen the same as was seen that the restoration of some spermatogenesis, if needed?
Yeah,
what do you think?
This is an excellent study. I read this papers, two papers now about mitotane treatment. An excellent idea to use mitotane, and as far as I can see, and not all patients had a very long follow-up, but this can be indeed for adults an alternative. Although mitotane also has severe side effects. In this patient, as far as I know, is not the side effects were limited. But for adult patients, that would make sense. Although I prefer newer medication that I think will be discussed in the next session, ACTH or CAH antagonists that probably give us more opportunities to lower ACTH, as I think this ACTH is really the growth promoting factor.
Hedi, do you think these ACTH antagonists will rather we will use them to prevent the development of TART, or to treat them, or both? Do you think they're capable of doing both, or what's your idea about this?
Just started with phase 2 studies. And this is one of the treatment goals, of course. We do not have yet data about the prevalence of TART in patients who are treated with CAH or ACTH antagonists. But I think when we have our children and adolescents under good hormonal control with a normal or nearly normal ACTH, I think then I think we could at least keep the tumors as small as possible.
Okay, thank you, Hedi. There are many questions, but we need to move on. I'm sorry, in my role of timekeeper. And I mean, people in the chat who ask questions can send their question maybe directly also to Hedi if needed. Thanks again, Hedi, and thanks for mentioning IFCA and the support you receive from IFCA.
Yeah,
appreciated.